To discuss about more, I would like to call upon a stage Dr. RITESH SHAH sir to discuss about the cardiopulmonary resuscitation, including a perioperative arrest. Over to you, sir.
Good morning. I thank Team Gujarat Criticon and Team Surat for first time giving me first lecture and that to CPR. So usually I am given a lecture post-lunch and my duty is to awaken you. But Anuj has already awakened you. And I was expecting unresponsiveness because my lecture is on CPR. But let us see, there are a lot of, rather 2025 American Heart Association guidelines are there. I am going to just narrate it, little bit of it. I have not covered about those guideline points which are already there, which were there and not changed except the level of the evidence. I am not going to touch upon because it's very huge. So this is basic life support. I will cover up. Do you have color mic? Color mic? Vando nahi. Just give me collar mic or head mic. All right. So regarding basic life support, what they have included is use mobile phone. All of us do use. But there is an evidence. See, this is important. Please remember, any small things that already we are doing, we don't document. All right. This is actually evidence that please use mobile phone, and it has entered into a guideline that, okay, everyone is having mobile phone, use wisely. For lay rescuer trained in performing CPR, it is reasonable to provide ventilation in addition to chest compression. Now remember, till last guidelines, there are only compression, only life support. Those who are not trained, but those who are trained lay rescuer, please try to provide breathing as well, ventilation as well, over and above chest compression. Yeah, I think it's a big change. So our duty is to train lay rescuer, as many lay rescuer to be trained as possible, so that this important part of ventilation is also well covered off, isn't it? Next is, we know that cervical spine probable trauma, head and neck injury. See, this is for an adult with head and neck trauma. If the airway cannot be opened with jaw thrust, we don't use head lift, head tilt, chin lift, all right? We use jaw thrust. But see, this is important change. Hello? 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 Am I audible? Okay, fine. So, for head and neck trauma, if the airway cannot be opened with jaw thrust and airway adjunct insertion, see, first you'd have to try jaw thrust, then airway adjunct. Still you cannot do it, please don't not try to open the airway. You have to try even with head tilt, chin lift, all right? Which is actually relative contraindication in previous guideline. The setting of an adult with head and neck trauma, lay rescuer should not be using rigid cervical collars which were not there in the guideline. So though we are trained, so we can use cautiously because we use kind of hand stabilization, all right? But those who are not trained, don't try to use cervical collar. When managing the airway of an adult with known or suspected basal skull fracture or severe coagulopathy, oropharyngeal airway is preferred compared to nasopharyngeal. Now all of us we practice, but it is in the guideline now, which is more important. The use of an airway adjunct like esophageal nasopharyngeal airway can be reasonable in unconscious, unresponsive patient with no cough, no gag. I am narrating it because there is an evidence for it. We were using it, this kind of airway, but the grade of evidence has also gone up. As far as chest compression fraction, it may be reasonable to perform with a chest compression fraction of at least 60% with good evidence. I'm not going to detail of what chest compression fraction is for the sake of time. And is outside of ALS, where invasive monitoring is available, there are insufficient data about the value of the pulse check while performing CPR on adult cardiac arrest. What I'm trying to tell you, that if it is happening in ICU or even outside, if arterial line is there, you probably do not need to check the pulse because you can see the trace provided it is properly done. As far as metrics that in adults, please keep your position or patient's torso at approximately the level of the vascular knees. So this is the position. All of us, again, we do it, but this is what the evidence is all about. In cardiac arrest, rescuers may consider placing the dominant hand. So far, there was no word used, dominant hand. Even if you are lefty, jamno hath muko. Or by default, lefty were left-hander was placing the hand, dominant hand. But now, dominant hand can give better chest compression if it is kept below. Change. Change the slide. Okay. Defibrillation, when placing pads for defibrillation, now see, might be reasonable to adjust the position of the bra. We know that male, female, irrespective of that, but I would say they also have evidence that don't try to remove undergarments. You just adjust because it will delay defibrillation and thereby the outcome might be affected. When providing ventilation for an adult with respiratory arrest, it is reasonable for healthcare professional to give one ventilation every 6 seconds. Previously it was 5 to 6 seconds or 6 to 8 seconds depending on airway is there or not. Away fix kar diyu chat. Give 10 breaths. That's it. Don't need to remember 6 to 8 or 5 to 6 seconds. Now this is important change as far as foreign body is concerned. For adults with severe foreign body which is obstructing the airway, repeated cycles of 5 back blows followed by 5 abdominal thrusts. What we used to do? Only Heimlich Mehrovier. No. Now you need to give both back slaps as well as abdominal thrusts. If we cannot give abdominal thrusts, back slaps and chest thrusts, like obese patient, pregnant patient, something like that. So it is not only Heimlich Mehrovier that you need to do. You need to do both back slaps as well as either abdominal thrust or in case of can't do, then chest thrust, which is important. Another important change is that when we used to do removal, Heimlich Mehrovier for removal of foreign body, if patient becomes unconscious, going into cardiac arrest, then the activation of emergency system was there. But now, if you witness foreign body, which is probably severe enough with the symptoms, you can know, activate emergency system at that particular time. So there is just time frame change. For single rescuer, over the head, tamar matha agad ubhu hoy toy bau wando nathi. If you are single, so that you can ventilate if you are trained rescuer. The heel or foot compressions, see they have tried कि हाथ थाकी जाएगा. Can we do it with leg, heel or foot? Because it does have more strength. But it is not recommended. Obviously the speed is not there. That's the biggest issue. You cannot give 120 chest compression and keep on giving it. All right, but they have evidence for that now. The routine use of mechanical CPR devices is not recommended except you are not able to do CPR properly or there is a fatigue. But because it tends to delay the defibrillation. So, force of compression, that's fine. CPR board, that's fine. Now this is the basic life support algorithm. There is practically no change except they are, favoring lot of things as far as naloxone is concerned for opioid overdose. Fortunately, we are not witnessing that badly as compared to USA or America. So, but they are very much stressing. There are a whole lot of pages and pages about, opioid overdose and naloxone. And this is what foreign body, as I already told. Now, I'll come to ACLS. Now, the usefulness of vector change for adults in cardiac arrest with persistent VFVT after more than 3 consecutive shocks has not been established. What we need to do? Shock, CPR, shock, CPR. Shock. If it's not working, still VF, we used to indicate here and there and there and there and there. It doesn't affect. So, stick to your position of the pads. And double sequential defibrillation is also de-emphasized. It doesn't help. Routine use of electrical pacing is not recommended, which was not there. Cardiac arrest pehla pace pad lagav deta tha. Ki probably patient goes in bradycardia, we just start it. Intubated adult patient, ETCO2, see this is very important where you should end. intubated adult patients failure to achieve end-tidal CO2 of greater than 10 millimeters of mercury by waveform capnography after 20 minutes of ALS resuscitation may be considered as a component of a multimodal approach to decide when to end resuscitative effort. So this is first time very much objective criteria that they have put that this is the cutoff limit, but you need to witness that not a single time the ETCO2 has gone up beyond 10 millimeters of mercury. All right. And now ultrasonography has entered. So far, it is not having very major evidence, but yes, you can use ultrasonography provided you have a team and equipment in place. And RTL line, as I already said. So, if ALS termination, BLS termination, I would say, arrest not witnessed by emergency medical service person, no return of spontaneous circulation before transport, and no AED shock. All three criteria present, don't do CPR. Any one criteria is present, you go ahead and do CPR. This is the same way as advanced cardiac life support. For advanced airway placement, yes, you can definitely use supraglottic or endotracheal tube. Now they have equivocal results, which is most important. You can definitely use LMA or iGel for this kind of purpose. And if advanced, that already covered. So, recommended for treatment of regular narrow complex tachycardia. Now they have removed the term supraventricular tachycardia and now they are using narrow complex tachycardia only. There is no mention of supraventricular tachycardia. So, synchronized cardioversion is recommended for hemodynamically stable. Unstable. But even stable narrow complex tachycardia when vagal maneuvers or drugs are not working. So still you can use in this case even if patient is hemodynamically stable. So this is kind of a new recommendation. Diltiazem, verapamil can be effective or beta blockers that I think we are already using. Now same way medical therapies for atrial fibrillation. I would say the change is now they have increased the dose of defibrillation to 200 joules even if it is atrial fibrillation. Otherwise, the traditional teaching, small atria, small joules, bigger ventricle, bigger joules. But now 200 joules even for atrial fibrillation or atrial flutter, which they have recommended. So go big, in short, if patient is unstable. Again, polymorphic ventricular tachycardia, lidocaine, amiodarone and measures to treat myocardial ischemia may be considered to treat recurrences of polymorphic VT in the absence of prolonged QT. That's fine. Magnesium, routine use, except torsades, don't use magnesium. That's what it is. Just don't give blindly magnesium. Sometimes it may cause more problems. In hemodynamically stable, wide complex tachycardia, I think if drugs are not working, anyway we go for synchronized cardioversion after good sedation. Even monomorphic wide complex tachycardia, they are recommending adenosine. Monomorphic wide complex tachycardia, adenosine, in last guideline there was a sentence, now the evidence has gone up. Remember, it has to be monomorphic ventricular tachycardia. So far, where we were giving so-called supraventricular tachycardia, hemodynamically unstable, we used to do adenosine, zupzap, something like that. But now in wide complex tachycardia, it is there. Verapamil, diltiazem should not be administered. See, whenever there is prolonged QT, you need to be careful. That's what, any antiarrhythmics can be proarrhythmics and can worsen or degenerate the rhythm into ventricular fibrillation or from monomorphic to polymorphic ventricular tachycardia and then degenerate into asystole. So this is what the ALS algorithm is all about. Again, not many changes except I say that atrial fibrillation and flutter, very important for us because we keep on, witnessing atrial. So if drugs are not working, go for 200 joules after sedation, all right? So this is what, I am not talking about unstable. Unstable things are very clear, anyway we go for the best. But even if stable, not working, vagal maneuvers in narrow complex tachycardia, drugs not working, go for synchronized cardioversion, and in atrial fibrillation flutter, go for 200 joules. I am not going into detail about the drugs otherwise. The bradycardia immediate pacing might be considered. See, if high degree AV block, anyway we had to go for pacing. But what they were saying that try simultaneously rather than one after the other. just evidence. So this is what, the same bradycardia algorithm, only one change, no major change. So this is what, adult cardiac arrest algorithm, 5H and 5T are remaining. And couple of, rather last thing I would say, what happens when cardiac arrest is there in cath lab. So they have included certain practice points which is published this year only. Shockable rhythms to delay chest compression, immediately administer defibrillator. See, anyway, in ICU we are practicing this. They are extrapolating. See, there is no ICU guidelines, all right? If you are witnessing cardiac arrest in ICU, there is no guideline. But now there is some, it is not AHA. This is just a paper. Probably in next guideline, they are going to include this paper also. And to rapidly switch from manual to mechanical chest compression, because you are witnessing it, to rapidly use cardiac echography and fluoroscopy to know the reason for cardiac arrest, because many times the tamponade is the reason for cardiac arrest. So go for ultrasonography and treat the cause. That's what they tend to say. And simulation based training. But they have also included that if needed, then put ECMO, even in cath lab, because you are having everything in hand. So they have included, it's not AHA guideline, again I'm telling you, this is just one evidence that is published this year, that is why I had covered, all right? So, and most importantly, perioperative arrest I had not covered because there is no change in the guideline as far as perioperative cardiac arrest is concerned. Only one thing, in CVTS patient, post open heart surgery patient, anyway what we used to do, open the chest and manual direct cardiac compression. And that is now entering into the guideline. Probably next time we may witness as an evidence that you do this. It is logic that this chest compression is not going to be effective, so you need to cut the wires open and then do it, all right? So I think that's it. Thanks for patient listening.
બધાને યાદ હે કે મોડું થાય છે તો ક્વેશ્ચન સ્કીપ કરે. નો, we don't want to cut down on quality. Any questions? Because say we have tried to put all the things. These are all practice changing lines. That's our theme line for the conference. So what a better person can than Ritesh can. On any questions on CPR or updates?
If any question you are asking me, and if I don't know, I'll write a letter to AHA and I'll come back to you, okay?
Can I ask a question, if I'm allowed to? The evidence behind the chest compression site is very poor. And actually, we are teaching CPR since almost 25 years now. We always felt that we need more data, and there are data coming up through transesophageal echo. So is there any mention about transesophageal echo guided CPR to better refine, that is called personalized CPR? Can you just give a quick comment?
As I said, that role of ultrasonography has entered into, it has opened the gates. But so far, there is no evidence as far as AHA guideline is concerned. If you are talking about certain articles, yes, there is some evidence that you see live. What else is required? It's there in front of your eyes. So what else is required? Logically also it is true, but yes, evidence is there, but yet to enter into the guideline.
So Taiwanese group has published transesophageal echo-guided CPR 101 case series.
Yes.
And they have concluded in more than 60% of patients we are not able to compress the LV at all. So we are really concerned as we are doing CPR. I would even ask Manoj, teaching so many years, any comment on this topic?
So the guidelines were released in October 2022-2025. એટલે દિવાળી દિવસે લોન્ચ થઈ છે. આમાં ultrasound has come in CPR. The chain of survival is now different. There are 6 chains of survival now. So all of you appearing for exam, please read that. 6 chain of survival. Ultrasound has come as a guide to thrombolize during CPR. So that's now in 2025. And the first time in the world, they have launched the training material also on 22nd October only. So whoever takes the course from this month onward, opt for the new course. There is a sandwich time till February 28th next year. कि जूनी guidelines पर लोगों बढ़ावे छे. But please attend the new course from this year.
Yes.
Thank you. Dr. Ritesh, any other question? The success of the lecture is judged by one, number of attendees, obviously, and second, number of questions you ask. It is the interaction that's going to make this session successful, not monologues. We need dialogues. So these are all experts sitting here. Please.
Use of supraglottic airway, new guideline.
Yeah, that's what I mentioned. Now, endotracheal tube and supraglottic airway, they are having equivocal, kind of equal results. So use LMA or use iGel, all right? They have said supraglottic airway and they have not compared LMA versus iGel. Anything that you are kind of, but it's again, it is not a definitive airway. It is a bridge. So you need to go ahead to secure the definitive airway as early as possible. So if no questions, thank you very much.